All right. Well, it's really my pleasure and honor to introduce Rebecca Alderfer. Rebecca has over 20 years of experience in service to big goals and high impact targets. Her work engages policy, resource alignment, and tenacity to inspire and affect change across complex systems. In March of 2023, Rebecca joined the Colorado Perinatal Care Quality Collaborative as the Chief Executive Officer. CPCQC is on a mission to ensure that birthing individuals and their families in Colorado receive culturally relevant, safe, equitable, high-quality care no matter who they are or where they live. Rebecca serves Colorado and her community as an active volunteer. Most recently, she was a board member of Social Venture Partners of Boulder County from 2022 to 24. She was also a 21 to 22 Colorado Governor's Leadership Fellow and served on the Lieutenant Governor's Alternative Payment Model Alignment Advisory Group. And in 2015, she was appointed by Governor John Hickenlooper to the Nurse Physician Advisory Task Force for Colorado Healthcare for a 2-year term. So Rebecca truly brings her passion and her expertise and her heart to this work. And today she'll be providing a policy update and the work that CPCQC is doing in this arena. Thank you.
All right. Good morning. Good morning. How many of you were affected by policy this morning? Did anyone have to drive the speed limit? Or choose to ignore it? Policy is everywhere. Clearly, I'm a policy nerd. I'm not a medical provider or a clinician. But hopefully, after today, all of you will adopt some version of policy nerdiness, or at least an engagement in how policy affects every single aspect of the work that you do and the way that your families experience care in the NICU or as they go home and care for their infant in the future. So as Susan said, I've spent my career in health policy, and it is ubiquitous, absolutely ubiquitous. So just to give a couple of examples, care payment is a policy decision. Employer benefits and the time that you get as a provider to spend with each patient, those are policy decisions. Establishing healthcare guidelines are policy decisions. And even whether a high schooler can carry naloxone with them in their backpack is a policy decision. So I'm hoping maybe after this conversation, we'll add one more paper to the wall that says policy issues that impact infant outcomes. And you can add to the list of things that you think my team and others should be focused on in this space as well. So just real quick, Susan talked about CPCQC. That stands for the Colorado Perinatal Care Quality Collaborative. I'm going to give the interpreters a minute for that one because it's going to take some time. But we refer to it as CPCQC. We are the state's perinatal quality care collaborative. There are perinatal care collaboratives across the country. And we really are working to impact outcomes for families across the state so that we have safe, equitable, high quality care no matter where you live or who you are. We do that in a couple of different ways. We look at the standard of care to ensure that there is that we're seeing less racial and geographic disparities in access and outcomes, which is very relevant to the conversation that we're having today, and also reducing the risk factors for preventable causes of maternal and infant mortality and morbidity. We're very, very pleased to participate with the DEFINE team, also with the CHOSEN team on making a difference in infant health outcomes. And then just real quick, as more of an orientation, we look at a lot of things at CPCQC. Maternal behavioral health is a big part of that. We had a conversation at my table in the back about whether or not when we think about translation and interpretation with families, we're also talking about their own health and well-being throughout the situation that they're in with an intensive care infant. We talk about patient safety a lot. We implement AIM patient safety bundles in hospitals across the state. We also provide technical assistance and lived experience. Infant care, which is clearly the focus of this conversation, where we look at newborn substance exposure work, NICU family engagement, which our team is very involved in, and are also starting to explore work around safe sleep. That's also a focus of infant mortality in the state. System change. Should be in bold. This is what we're talking about today. Policy and practice reform, community engagement, advocacy. And then I won't go into the rest, but I think one of the things that my team is always focused on is innovation. So what is the next frontier? Where are we missing the mark in being able to provide the safe, equitable, high quality care across the state to everyone? Policy and advocacy. If I asked you to close your eyes, how many of you would know the difference? Got a couple. Those terms are used interchangeably. And as Susan was just saying, definitions matter. And in policy and advocacy, I think definitions matter a lot. Because a lot of you are probably advocates, whether you're aware of it or not, or you could be advocates. And you're probably also able to affect change around policy. So policy is a set of rules or principles that guide decision-making. I gave a couple of examples of those earlier, but advocacy is the act of promoting an idea or a cause to influence policy. So every time you speak up about something, every time that you raise concerns and offer solutions, you could be considering yourself an advocate or participating in advocacy. So CPCQC gets involved in both policy and advocacy pretty much on a daily basis. And we sit at this really interesting intersection between the making of policy and the implementation of policy. And those two things are really necessary to go hand in hand. How many of you have seen the movie Field of Dreams? Oh, there we go. Now we've got everybody. I am from Iowa. And so the Field of Dreams movie is very important to me because they say how great it is at least twice, maybe 3 times in the movie. But one of the key lines from that movie is, if you build it, they will come. And I think a lot of times when we think about policy, we figure if we just pass a bill, or if we just change a hospital policy, or if we just have a unit policy get edited, that things are going to be different. I would posit that oftentimes things are not different, or at least they're not different immediately, right? And part of that is because there's a huge amount of work that needs to go into policy implementation, which is making those changes a reality in the practice of day-to-day care, of the practice of the culture of the hospital or of the facility, or in the lives of the patients that are being affected. And so when I talk today about policy, I'm less interested potentially in that change. It's very, very important, but then it's also, how does it get put into practice? And a lot of that is quality improvement. A lot of that is education. A lot of it is accountability and measurement. And so these are the things that we need to think about when we think about policy implementation and how changes in rules become reality. There has been a lot of policy change in perinatal health and infant health over the last probably 5 years in Colorado. This is not a comprehensive list of all of the things that have happened in sort of the policy space. And each one of those requires a concerted effort to then make those policies a reality out in the field. The 4 that are highlighted in yellow are ones that I'm just going to kind of walk you through a little bit today in this conversation. They seem the most relevant to this group, even though probably any one of these we could spend 40 minutes talking about. What is it? Why does it matter? Who cares? How is it being implemented? What does this mean for my job, my work, my families, my outcomes? before I walk into that, one of the things that I want to talk about is sort of the policy process. And I have to find my notes. Okay. The Centers for Disease Control, they have something called the policy life cycle, and they have this really great graphic on their website, which I should have put on one of my slides. But there's a whole life cycle to policy. The first one is problem identification. How many of you thought you knew what the problem was only to find out that that actually wasn't the problem? Anyone? Okay. For example, families are missing appointments at the clinic. And you assume that it's because maybe the clinic isn't open at a time that the families can come. But once you do the research, it's really because the bus schedule doesn't align with the times that folks had appointments, et cetera, et cetera. Knowing what the problem is absolutely essential, because if you don't understand what the problem is, you can't make good policy. So for example, is the policy around skipping rooms to wait for a translator the real problem, or is it that families don't understand what's going on, and that could be fixed pretty easily and it doesn't require a big policy change? So one of the things that we talk about is, what is the problem? You need to have a really good understanding of that. You need policy analysis. What do we think the effect is going to be? If we make this change, then what, right? How does that trickle down? You need strategy and policy development. How are we going to get this implemented? Who do we need on our side? Do we need the hospital administrator to sign off on it? Do we need legal? Do we need the risk managers? What about the nurse managers? Are they going to be on board with this and be a proponent? There's policy enactment. So actually getting the thing passed or written into hospital policy. And then there's the piece that I talked about, which is implementation, making that a reality in the day-to-day experience of care. My team probably spends 2/3 of our work right now in the implementation phase, and much less so on sort of those 4 pieces of work in advance. So let's walk through a couple of things that are happening in real time in Colorado. One is a policy that provided resources to purchase donor milk or procure donor milk, especially for intensive care infants that are experiencing intensive care services, and also providing the ability to have a doula through public insurance, right? That Medicaid would pay for folks to be able to have a doula present throughout their pregnancy and postpartum. And so what we've done is sort of break down this policy process for you. What was the problem that people were trying to address? What was the solution that was put forward and then enacted into law? And then what has been the impact? And I will tell you that so far, most of these policy changes are so new that we don't really know the impact. And a lot of times what you find after you get to implementation is there might be some unintended consequences, right? Things that we thought were going to be beneficial, things that we thought the solution was going to address don't end up being so. And sadly, oftentimes it doesn't get fixed, right? We don't go back to the table and say that didn't really work. What should we do differently? And yet I would suggest that we should, right? It's the PDSA cycle of policy is then you should go back and fix what you got wrong. So the doula benefit only went live on July 1. And I'm guessing if we had the Department of Healthcare Policy and Financing here, they would tell you that there are a whole lot of things that they didn't anticipate, right, in implementation of this policy, and things that they are going to have to tweak or think about differently moving forward. I'm just going to keep cruising because I want time for questions. Another very real-time policy discussion that's happening in Colorado is around safe perinatal transfers. There's a movement to really make sure that we have opportunities for folks to birth outside of hospitals, that there are community midwives available, that there are birth centers available, and potentially even families that would like to experience a home birth. And one of the core problems is how do you make sure that you have a system in place that then allows for a change in risk factors that makes that plan unattainable? And there is a whole lot of issues that go into having a safe transfers policy of what does that look like? What kind of communication and forms and risk and liability and acceptance. And the state is grappling with that right now. There have been a few solutions passed, and we are very much in the implementation phase and understanding that the conversations require a lot of stakeholders, they require a lot of partners, and it certainly requires a lot of voices, including voices of lived experience, of community midwives and doulas, of hospital providers, of administrators, of sadly lawyers as well in the process. These are meaty slides. So maybe they'll come out in a packet or so you can read more about each of these policies. Another one that we've been working on, and we work with Chosen, the substance exposed newborn program, quite a bit on this, is around toxicology testing. Many of you, if you work in sort of neonatal care, will understand that this has also been a very hot policy topic in Colorado and across the country, as we've seen substance exposed newborns I always say this wrong, so I'm going to look at my notes. Neonatal opioid withdrawal syndrome increase massively across the country. And so what is the problem? We were seeing very unequitable uses of toxicology testing. We saw that data suggested that toxicology tests were often unreliable or found things that weren't necessarily put into context. And we were seeing hospitals have very disparate approaches to how they were implementing toxicology testing and reporting, following up on that. There's been several solutions put on the table. And again, we're smack in the middle of implementation right now, where we're working with hospitals across the state on not only understanding what we've learned from the research and from the data, what the policy changes actually were. So one of the things that I think we've learned and would love to hear from the audience about your experiences, oftentimes hospitals don't know that the policy has changed at the state level. You know, it's really that lag between something changing in law or policy and then actually getting shared across the state. And then how is that sharing interpreted? And then how is it actually put into action? All right, Brace flashed me the 10-minute sign, so I'm going to move a lot faster. I'm going to give you a couple more updates, and then hopefully maybe you have some questions. So one of the things that I work with quite a bit is the Maternal Mortality Review Commission. I know that this group is very much focused on infant mortality and outcomes and the experience of infant care, but I think a lot of times we're working with Susan's team on sort of that dyadic relationship, that the health and well-being of one is very much important to the health and well-being of the other. And we've had increasing maternal mortality in Colorado, just like every other state in the country over the last couple of decades. And so the objective is, what do you do about that? And policy has a big role to play. The Maternal Mortality Review Commission puts out recommendations. There's currently 24 of them in their last report. I think there's actually maybe even a few more than that. But one of them was around making sure that we are doing quality improvement regularly with hospitals, that we're focused on preventing all of the preventable deaths. And so one of the most recent legislative acts is around improving hospital quality improvement and data access. It's called the Improving Perinatal Health Outcomes Act. It was passed in the last legislature and is currently now, as you can imagine, it's sort of the constant refrain in the implementation process. But what this bill does is make sure that we have engagement of 100% of birthing hospitals and neonatal intensive care units in ongoing quality improvement around the leading causes of maternal and infant mortality and morbidity in the state, and that we're sharing out what we're learning from those as much as we can publicly, if not very detailed, in-depth work with each facility around what their data is telling them. And I think the biggest piece is disaggregating all of that data by race, ethnicity, and language so that we can look at the outcomes that we're seeing in neonatal intensive care units. We can see the outcomes in birthing units around, are we getting the same results for all of our Black mamas or our Latina mamas as we are for the white or non-Hispanic patients that are walking through our doors? And the answer right now is no. But we're hopeful that through implementation of this work, the answer will start to be more and more yes. I'm not going to go into details on this, but I can share them with anyone who wants them later. So looking ahead, you saw that slide that showed how much policy has been made in Colorado around perinatal health over the last few years. Some might ask, do we really need more? Or do we just focus on the implementation of all the things that have already transpired? I think it's a little of both. There are still things that at least my team and others want to make sure that we focus on. One is around, what does 12 months of postpartum care really look like? Medicaid recently extended their coverage to 12 months postpartum. And yet we don't have a good sense of who's going to provide that care. What does that care look like? How are they going to pay for that care? How is anyone going to know what's available to them and what they are actually able to receive as postpartum care? So there are a lot of policy decisions yet to be made in that space. The other is around rural perinatal health access and patient safety, especially when you have vulnerable infants, medically vulnerable infants, and high-risk pregnancies and others. We need to be thinking about how we make sure that folks in more of the frontier communities are able to access care, that they have high quality care and safe care, even if they're not in close proximity to a hospital or one that has sort of a higher level of capabilities than maybe the hospital in their community. And it's very complicated. It comes down to economics and workforce and technology and other policy decisions that are going to need to be made. And the other is around suicide prevention and also prevention in perinatal mental health. I think we've talked with the NICU, the Define team, quite a bit about the fact that we know that parents that have children in intensive care have a higher rate of instances of maternal mental health issues around depression, anxiety, OCD, and others. And so how are we focusing our work on making sure that we have the supports in all of our facilities and integrated treatment, but also prevention? The research is becoming very clear that we can prevent a lot of perinatal mood and anxiety disorders if we get out in front of those issues from the get-go. I'm going to skip through this because it's really just backing up why those things are priorities. But the last piece that I'll leave you with is that our team also want to make sure that family voices are a key part of any policy process, whether it's identifying the problem, whether it's the strategy, whether it's the analysis of what the impact would be, or how it gets implemented. And one of those programs is the Families Integrated to Restore Trust program, or FIRST. And both Brace Gibson, my colleague in the back, and Tyler Jones are really leading that work for the team. And I encourage folks to reach out to them about, if you want to be a more vocal advocate, if you want to get involved in policy discussions and how those get implemented in facilities, to think about joining this work as well. With that, I'm going to stop and take any questions that you have.
Thank you so much, Rebecca. Clearly, there is a lot happening on the legislative front in our state. Let's open it up for questions. I'll get us started. I'll say that for most folks that work in hospitals, there still is like this disconnect between what happens at the bedside in sort of our day-to-day life and what's discussed in the policy arena. And so everything that you presented, and I'm intimate in the work, still it feels a little distant and abstract compared to what we have to deal with at the bedside. And so just curious to know what efforts are there either within CPCQC or other organizations that make it more relatable, more understandable to people on the front line. And then my second question is, many of us have experiences and want to make change that may not necessarily be captured in all that you've listed. How do we get our voices heard and our priorities put up the list of things that people want policies passed about?
Oh my gosh. Those are really good questions, Susan. And I fully understand that there often feels like a very vast gap between your day-to-day work. We just talked about it, right? Like we don't think about how policy is affecting almost every single decision that we're making, right? And I think some of the folks that I work with regularly will tell you it can come down to just a policy decision about what's available to put into your EMR, right? Around somebody's race, ethnicity, and language, or the kinds of medicines that are available for you to order for folks that maybe are suffering with substance use disorder. My advice for folks that are at the bedside is really to do sort of a mini problem analysis, if you will, as you kind of work in your units. Think about things that are affecting the outcomes that you see. What kind of data do you have to support that? And then really raise that up to your unit leadership or present at maybe a council in your facility. From the other way, how does it get translated back? I'm gonna have to think about it a bit because I know our team does a ton of work with hospital facilities, nursing and L&D teams to share with them kind of how these policies get put into hospital practice. We do that through learning collaboratives. We do that through webinars where we share information with hospital teams. But we're certainly open to ideas that folks have around how do we make policy changes more real for folks so that they can kind of think about how what it means for them. The other question that you had was,
How do we get our voices heard and our priorities on the radar of policymakers?
absolutely. A couple of different ways. One, you can talk to our staff. Two, I definitely would recommend getting involved. If you're an interested clinician, we have a variety of steering committees that work on policy issues around substance use, around new patient safety bundle selection, around family integration, around infant care. And so definitely reach out